Hey everybody, this is Professor Butler, and this is going to be your brief presentation on some general pediatric interventions. This is for section one of the course, and it goes over again several areas in the textbook. Please refer back to your course schedule or Canvas where you can get some details of what pages you can find more information that you need to read on. So the first thing we're going to start is medication administration. Not that different from when you're administering medications, but it can obviously be a little bit tricky when you are giving medications to a child, especially depending on their age. Um, so we give oral, rectal, IV, we'll talk about in a second. This slide focuses specifically on oral and rectal. You have to take into some considerations of their developmental stage and developmental ability to cooperate with any type of medication administration. So looking at all of those factors as well as if they can swallow. We do have children, obviously, who have some cognitive impairment or some neurological deficits and may not be able to swallow effectively. When we are giving medication, as you can see from this picture, usually looks like it's probably like just a child who's just under 2 years old. We always want to give it to the side. We never want to shoot the medication straight down into the back of the throat. And we give a little bit at a time. So like point one or point two, put it in the side where their cheek is. Sometimes you may have to hold the cheeks, squeeze the cheeks together so that they can't spit it out. And then, you just I just go, from one cheek to the other. Obviously, if the child is able to do it, if they can participate in the administration, that's great. Our medication administration is very precise, so we usually draw them up into syringes. We do not use teaspoons or tablespoons when we are calculating our dosages. We may communicate to family members whether it's 1 teaspoon or 1 tablespoon or something like that. But that is for lay people, not for healthcare professionals. So we never want to write tablespoons or teaspoons. We do a lot of crushing and mixing. Now, remember, you should not mix anything in food. So we might mix it in some type of flavoring so it doesn't taste as bad when the child is swallowing it. But we never mix it in a bottle. We never mix it in a large volume of food, because if they don't finish the food, then obviously that's going to be a problem when we don't know if they got the full dosage of the medication. The other reason is we don't know if the food is going to affect the pharmacokinetics of the medication. So it's usually a good idea to not do it unless it's absolutely recommended, or if you just need to put some flavoring in there. When we do crush and mix, a lot of time what we're doing is creating a concentration. So we will be doing some of that in the med pass or the pediatric lab. And all that means is that if you have a certain amount of medication in your hand, let's say 10 milligrams of prednisone tablet, and the child can't take tablets, but that's all that you have. So you're going to have to crush up that tablet and then put it into water, and then now, let's just say I put it in 5 milliliters of water, and now I know I have 10 milligrams per 5 mLs of prednisone in my hand, right? As a solution now, not as a tablet. And then we can administer it either in their mouth, like you see here in the picture, or we're going to go ahead and put it through the G tube, whatever route is ordered. So I'm looking at my slide here because I always jump ahead. So rectal administration. So I've kind of covered everything oral. So rectal administration, remember, you do not use rectal administration for neutropenic child who also is thrombocytopenic, meaning they have low platelets or have some type of immune compromise, or our HEMOC population. We would need to have an order in order to be able to do that, because that can increase their chances of infection. If you are giving a partial administration of a medication, if it's scored, obviously we like for you to go lengthwise. Another thing where this applies is if you have a suppository, you're going to cut it lengthwise, not in the halfway. So you're going vertically, not horizontally. And rectal administration is something that we do a lot, especially one of the main rectal administration is Tylenol. And Tylenol is given when obviously we have a child who cannot tolerate anything orally. So now going into our injections, and this slide kind of talks about a lot here. So we have to take in consideration the needle length, obviously the site, all right, the age of the child, how much adipose tissue the child has, and then just what is going to be the safest way to do it, especially if you have a child who's very combative. So different things to think about, but first let's focus on the needle size and the gauge. So this illustration, this chart here tells you the patient's age, it tells you the size. And so typically, as you can see, we can use anywhere between a 22 gauge to a 25 gauge needle. And that is going to depend on the vesicosity of the solution. For example, Rocephin is a very thick injectable medication. So we probably are going to use a 22 gauge if we can get away with it. Remember, a 22 gauge is really big. The ideal one we use all the time is a 24 gauge needle. That's relatively not as painful, but it's not as small as a 25 gauge, where you're really going to have a hard time pushing that medication through the needle gauge. The length of the needle is going to depend on how much adipose tissue. So this little child sitting here on the father's lap, he has a good amount of adipose tissue. So I would probably use a 1 inch on him if I was going to give him an IM injection. All right. We usually only will use the anterolateral thigh muscle or the vas lataris, which is the side. And those are the ones that typically the sites we use for our younger child. There is another site called the ventral gluteal, which you will read in a book, and I want you to make sure you do read about that. This site is not preferred because we don't really teach that site very well in healthcare. And it's also a site that we don't have good control, but it's a great site for an IM injection. The deltoid is used for our older children, as you can see here in this picture here. And it's for children who have enough muscle that they can actually get an injection in the deltoid. All right. So we have a lot of different sites depending on their age. We also have to take into consider, we talked about the gauge, we talked about the length. And then another thing I also want to mention is the holding. So as you can see here up here, the nurse is holding, and she's in a great position. And we do that. Usually the kid is screaming their head off. But when you're giving an injection, you do want to make sure that you have control of that area. You have to grab them, you have to hold them still so that you can give an injection and not harm yourself or the child. Here, I think the parent is helping by holding the arm. And then up here, sitting on the parent's lap for a young child, definitely that is a very popular position. Now, the amount of solution that can be injected at one time typically you're not supposed to do any more than 0.5. If we have solutions that are very large, what we will do is we will split them into two syringes, and then we will both give the injection at the same time. So, for example, the child right here right here above, um, the child will actually be facing out to us, and then we would split the amount of the injection. Let's just say I have zero point 0.5 in mine and the other one has 0.5. I know we can give a little bit more than that, but I'm just talking to you about the double injection technique. And at the same time, one nurse on one side and one nurse on the other side. Let's say we're doing the vas lataris, and then we would count off and we'd be like 1, 2, 3, boom, do it at the same time. So this is get done because typically we don't want to stick the child twice, even though we are sticking the child twice, but we don't want the child to have an episode of getting prepared to get stuck twice. Does that make sense? So that falls into the category of traumatic care. So we don't want to traumatize them twice. We want to do it all in one time, and therefore that's why we do the double injection. So your book will have recommended needle sizes, depending on their age. And again, those are recommended, but you do have to take in consideration the adipose tissue, because we could have children who are malnourished, who have diagnosis of failure to thrive, and those children really do not have any fat on them at all. And we would really have to, even though they're probably up there in age, I probably would use a 5/8 needle, just so that I make sure that I don't hit the bone. So IV sites. So in pediatrics, getting an IV in is can be a little tricky. Usually it takes time for nurses who start pediatrics to get the hang of starting IVs. They do have IV teams. I've majority obviously worked in the ICU, so we were the IV team, and then the IV team would come if we really had a really bad stick. Because her skin is so thin, especially neonates and infants, it's very easy for us to transluminate the veins. There's lots of different technologies out there, like, the ultrasound, then we have the one that's above that transluminates the veins in the adult world. But we can use any light as long as it doesn't burn the child, and translumin, you can see their veins. I've used this a million times to be able to get an IV in these little veins. Sites can include all the sites that we normally use, and in infants up to 9 months, we can use scalp veins. Scalp veins are last resort. So you pretty much have used all of your other areas, or they're not available, so to speak, and you have to go to the scalp. Scalp veins, you have to be very careful that they don't infiltrate, because if they do, then that can actually cause some serious issues, not only for the cranium plastic surgery standpoint, but remember the brain is right there and their fontanelles have not closed. All right. If we do have to do any shaving, it's always recommended to keep the hair clippings for the parents and offer it to them. And if they don't want it, then they can throw it away. We do have some special infusion devices called the Medfusions. There are some other type of pumps besides the Medfusion pump. We do use that at children, so you will get an opportunity to play with that and to see with that. There's some slides coming up about it as well. So the special infusion devices are for smaller volumes. So we have small volume medication administration. This is one of the concepts for skills that you do need to know from a pediatric standpoint. I did check your Evolve skills thing, and I don't see it there anymore, but I know that small volume is something that they may test you on. And it is a concept that you do need to know, for not only for my exam, for NCLEX, and just for practice. So I'm going to talk about it in a little more detail, probably in class if we have time. If not, then we are definitely going to go over it in MedPass. But in general, basically, there's a way and a technique that we infuse very small volumes. We can, like, let's say 0.4 mLs of a medication that needs to be given to a child. But we do not push medications. Well, let me just back up. A lot of nurses do not push, or not trained to push medications into pediatrics. You have to be trained to do so, like in the ICU or special areas. So med surg floors are told that they're never to push anything unless it's an emergency. All medications are administered via a pump through a medfusion or a small volume medication administration device. And we don't stop anything. So that whole primary and secondary piggyback thing is not really a thing in pediatrics. So we run everything together. So if a child has IV fluids running that are maintenance fluids at a rate of 25 an hour, they run at 25 an hour continuously. If they have a medication or medications that need to be given, we have a way of setting up the line so that they can get those medications at the same time. We do not interrupt the primary infusion to give an intermittent infusion. Okay. The only time we will stop stuff is if there is an emergency. We have to look at the compatibility, obviously, if we have multiple things running together. And you also need to make sure that the line itself can handle all those infusions running together. If they cannot, then you need to get another IV site. If for some reason you do have to push a medication, it is very important to use the closest hub. So go to the closest area, which typically would be the T connector, which is the connector that you flush with normal saline after you get the IV in, the catheter in, and then you connect that saline primed device to the IV catheter. That's called the T connector. And so going all the way down to that is considered the closest to the patient. We do not go use a Y site, and the Y site is usually where you would hook up your piggybacks or your secondary line that pauses a primary if you have to give an antibiotic or something, if you've seen that in the adult world. That doesn't exist here. I have never, ever, ever in my 30 some years of practicing in pediatrics and neonatal ICU, or even in a med surg floor, we do not pause. We do not put anything through a Y site. And so you'll see more of that when you see it in lab. It's just the concept of knowing that you do not um, do that, and that if you have to push something, you have to go to the closest site, which is usually the T connector. When removing a device like an IV, you always want to consider atraumatic care. We have tons of different things that will dissolve the what I'm going to call the adhesive on like the tape, special tapes, the tegaderms. Oh, the tegaderms hurt, you guys. They hurt. I've had one ripped off of me, and then I was at shock at how much it hurt. So, but there are tons of things that we can use and techniques that you can use, not necessarily chemicals, techniques that you can use to removing these things that will make it easier and less painful. And this is also going to be based on age as well. All right, so this is the Med Fusion pump, and the Med Fusion pump is just like that, and you'll see that in children's as well. And we also have several of them in our labs that you'll be practicing on. And it's typically a very simple thing. I don't know if this is a link. You can try it. I'm not going to do it in the middle of this, but I do have a video that I made during COVID because we were homebound and I had to show them how to give small volume medication administration. Now, I did do it very slowly. So I'm not really going to recommend you watch it in its entirety because I do go over the Alaris pump, but you do need to know this one main rule. The rule is if the volume that you're giving is less than 1 ml, okay, you need to push that into your line. So this is the line, as you can see my cursor. This is the line, and this is the line that's going somewhere down to your patient. This is the medication. So when you are if this medication is 0.75, for example, which is less than 1 ml, you're going to push this into your line, and then you're going to put on a flush, and you're going to program it in a way so that your medication and your flush is delivered at the same time. So let's use the example of this medication being 0.75. So I would push the 0.75 through. Let's pretend that this is my flush. I put my flush on, and then I would program my pump and I to be 3.75 mLs over 30 minutes because my order states to give this medication over 30 minutes. I've decided to use a 3 milliliter normal saline flush. And so my flush is on here. I know my med is 0.75, and I also have a flush I'm adding to it together. So I put them together, so 3.75. And the MAR says to administer it over 30 minutes. So this apparatus here, I would set it to give 3.75 milliliters over 30 minutes. This video is the video that I made back in 2020 when We were in COVID, so you definitely can click on this as you can see, and you can access the video. Again, we will be going over it. The main thing I want you to understand is that, again, if it's less than 1 ml, you push it into the line. You don't prime. Priming means you have air in the line and you're priming it with whatever solution you're doing. Priming is not the right terminology. Pushing it in the line means that you already have normal saline primed in the line and you're pushing your medication out in that. So that does mean that you're pushing some normal saline into your patient, but it's a very, very small amount, and it's not significant. Okay. So be careful when you're reading choices, hint on the test, whether it says prime or push, okay? Then you're taking the number of the volume of the medication and adding it to the volume of flush that you're using, and you are going to program the pump to administer it over the time stated by the MAR or by the order. Oh, yep, see, it was about to come up. All right, I'm just gonna go this way. All right. And so let's change over from IVs into enteral feedings. So there are 7 rights of feedings that I want you to know. So we always talk about medication administration and all the medication and the 5 rights, the 6 rights, the 7 rights, depends on who you're talking to. Um, but we have all these medication rights. But nobody really talks a lot about the rights when it comes to feeding, because you can really harm somebody by giving them the wrong feeding, feeding it too fast, not using proper technique, and then feeding it into the wrong place. So let's just kind of go through these. So what you see here is just a setup of things typically you're going to need in order to check placement, right? So you want to make sure it's in the right place. And then stuff to kind of dilute your solution so that you're giving the right concentration of your feeding, and it is also the right calorie. So every box, I'm going to use my cursor, has down here, this one has down here, and this is a YouTube video, but you don't have to watch it. Um, this has a certain amount of calorie, so you want to make sure your patient is getting the right calorie. Make sure you have the right syringes. Make sure you have the syringes for the job, because we use Lorlock only for IV, and then we have the infant syringes for enteral or Medicaid or anything gastric administration. Stethoscope is here to listen. You've got your pH paper, and the measuring is there for measuring it depending on which tube you're going to use. We're going to talk about that in a second, which is a G versus a J tube, which is the last slide, because I told you this is a very short presentation. All righty. So the 7 rights. All right. First right, you gotta have the right patient. Right? You gotta have the right patient. And you need to have the right route when you're feeding. So are you going to go gastric, jejunum, right? Is this going to be NG, OG? Which route, right? You have to have the right feeding or the right medication. Right? What is the formula? What is the calorie? What is the concentration that you're having to use if you have to dilute it? Um, right calorie, that's number 4. Right, number 5 is the right method. Are you going to be giving it as a gravity feed? Or is this just an intermittent bolus over an hour, over 2 hours? There's another type of feeding method, like it's called trophic feeds, that we use in in the neonates. Um, and excuse me, is it the right, are you giving it at the right time? Have you calculated the right rate that this is supposed to go at? Meaning milliliters per hour of the feeding. And is your patient responding correctly? Because you can start a feed, and then after a while, they can show you signs of intolerance. They get very fussy. Their vital signs are changing. They may throw up, right? And so these things that we see, if we see these after we're starting a feed, we usually have to stop the feed because we're causing gastric distress. So if you're giving medications, we look for the right response. Let's just say, for example, pain medication. I give a pain medication, I expect my patient to not be in pain. Maybe their score will go down. Maybe their vital signs will change because they're more relaxed. If somebody has a fever, I expect it for them to be, the fever to go down. They may actually break the fever. You get the point, right? So you want to make sure that when you start feeding, that it's not causing them discomfort, right? That they are actually, getting the feed. All right. And then I don't think, yes, I did. Yes. So I'll go through them again just to make sure we're clear. So the right patient, the right routes, which also means the right placement, meaning you making sure it's in the right place. When we check a tube, now this keeps changing it, Joe, and I need to pull the policy. But ideally you have to have two confirmations if you're putting down a nasal or an oral tube feed. So we no longer use, auscultation, so that you have to make sure that you either get gastric secretions and then check the pH. Also, the golden standard is an X-ray. X-rays are required for J tubes, which I'll talk about in just a second. But nonetheless, you have to have two methods of confirmation. And so that was number two, the right route and the right placement. You have to have the right feeding. That's number three. Um, you have to have the right calorie. That's kind of like your dose. You have to have the right method. Is it going to be a bolus? Is it going to be intermittent? Is it going to be a trophic feeding? And then you have to have the right time. So you're infusing it at the right rate so that it is delivered over an hour, 2 hours, or continuous or whatever. And then you want to make sure the patient has number seven, the right response to the feeding. So last but not least, we have our enteral feeding types. So we got all these different type of tubes that you will see when you go into the practice. If you have not seen a lot of gastric medical stuff, you'll probably definitely see a lot on this in this clinical rotation. So we have gastric tubes, and gastric tubes. How I like to describe or differentiate them is you have tubes that are surgically placed, and then you have tubes that are temporarily placed. So this one up here, for example, as you can see, is surgically placed into the stomach. Anything that's placed orally or nasally is temporary. It's considered a temporary tube. But when we start putting in the stomach, that is a surgically placed G tube. So just like orally and nasally, surgically, those temporary tubes, they can either be placed in the jejunum, in the small bowel, or in the gastric, G for gastric, which would be in the stomach. Here's a good picture of a combination where we have a surgically placed tube. This is a Mickey button where we have this port goes into the stomach and this port goes into the small bowel. All right, so need to go back up to the top. So we got our gastric tubes, NG tube, which is our temporary, our G tubes are our surgical tubes. We have different types of tube like silicone tubes. We talked about tube conformation for exertion if you're doing a temporary tube, jejunal or duodenal tubes, also called NJ, TP, or J tubes. These are all in a small bowel. These are usually placed for patients who have high risk for aspiration or cannot tolerate anything in their stomach. They also, if we're putting it temporarily, we would use weighted tubes. And here's a picture of a weighted tube, very common tube. Um, and it's inserted by a trained individual, and x-rays are required when you're putting in anything into the small bowel. All right, so that would be the definite confirmation that you're in. You're not going to get gastric secretions back. Why? Because you're in a small bowel. There's no gastric secretions in the small bowel. Okay. It's just trying. And so when you look at that x-ray, and that's why also another reason why we like weighted tubes, because these light up on the x-ray and we can see it cross the pyloric sphincter, right? You guys, so pyloric sphincter is the entry into the small bowel. So when we see the cross over the pyloric sphincter, we know that this tube is in the right spot. All right, now we have tubes. So I just talked about all these tubes to feed our kiddos, tubes for feeding. So that's what I talked about right here, all these tubes for feeding. We talked about the small bowel and the gastric tube and so forth. Now, let's talk about tubes for pulling out, for also called decompressing. So decompressing, usually there's two tubes that are very common. I know that there are other ones out there, and we'll talk about another one when we get to the end of the semester. But this one is a Salem slump or Rapogel. You use the Rapogel when you were in lab for foundations. And these basically are to constantly decompress or intermittently decompress. So typically we'll see patients with this after surgery. If you have somebody being decompressed, you're not going to be feeding them in the same place because all you're doing is putting in and taking out. That doesn't make any sense. So this is usually somebody after surgery, and we just want to keep their um, stomach empty, because just because somebody is not eating does not mean that the body is still not going to create gastric secretions. So we have to constantly decompress the stomach so that they don't get a stomach ache and then throw up all over the place. All right. With all of these tubes and sites, especially if it's a surgical one that's placed, we always have to care for the site, right? So if it's a surgical one, as you can see, there's a stoma, so stoma care applies there. We want to make sure that there's no oozing. We want to make sure there's no gaseous secretions coming out through the stoma. Make sure it's a tight fit, so that they don't get any burns. Also, um, this is granuloma tissue that's kind of oozing or building up around the site. This is something the specialist will be able to take care of. Those actually can bleed and become an issue and irritating at the site, which is why, as you can see up here, this little one has a little bit of a comforter or a little bit of a pouch around the site. So it makes it kind of comfortable and keeps their hands hopefully away from the site. But we also have care of sites if we have a temporary one where we want to make sure that the tape isn't irritating or having a reaction to whatever tape, and making also sure it's not taped down so hard to their face that it causes a pressure sore, which can happen right at the septum of their nares. I've seen that happen a lot. And they sometimes have to have plastic surgery because we messed up the look of their nose, I should say. So it's called like a necrotic area because it was a pressure sore right there on their nasal septum. All right, so that's all I have for that. Very general stuff, but I wanted to make sure that I introduce all this to you. And you can refer back to this later on. But again, this will be on the section one quiz as well on your exam one. Let me know if you have any questions.